Hello, everyone. Welcome to another presentation in the Ocular Emergencies and Trauma series. My name is Dr. Richa Pyare, and I am a UVA and medical retina consultant at Shrophi Center, Delhi. Today, I'll be talking about Vogt-Koyanagi-Harada syndrome, or VKH. Let's start off with the definition of VKH. VKH is a multi-system disease. There are ocular, dermatological, neurological, and auditory involvements, but the ocular symptoms predominate. It is a bilateral granulomatous panuveitis with a chronic recurrent course. The exact etiology is still being explored, but it is presumed autoimmune, which means it is an immune reaction against a self-antigen. The most likely target is melanocytes. There are 4 stages. The prodromal stage, when the patient has flu-like symptoms. The next is the acute uveitic stage, where patients will have blurry vision, redness, pain. This is followed by a convalescent phase with findings of sunset glow fundus, alopecia, poliosis, vitiligo. And finally, chronic recurrent stage is marked by repeated bouts of anterior inflammation. Now, let's try and understand VKH using some case scenarios. A 37-year-old lady presented to my OPD with complaints of headache for a month and diminution of vision for 10 days. The BCVA in the right eye had dropped to 636 and in the left eye to 615. There was inflammation in the anterior chamber and in the vitreous. Now, this is the fundus picture. There were multiple pockets of subretinal fluid in the eyes, and the optic disc was hyperemic with blurred margins. So there is inflammatory or exudative retinal detachment. There are no mass lesions, no choroidal, retinal, or retinal vascular lesions. At this point, the first differential that comes to my mind is already VKH, followed by sympathetic ophthalmia, bilateral posterior scleritis, and multifocal CSR. The presence of inflammatory reaction that is cells and flare in the anterior chamber and in the vitreous rules out CSR. And there was no history of trauma or ocular surgery, so that rules out sympathetic ophthalmia. Bilateral posterior scleritis should be accompanied by pain on ocular movements and is unlikely to have such an exuberant exudative retinal detachment. Now, imaging is essential to diagnose VKH. OCT will confirm many important biomarkers. Cells in the vitreous can be seen as hyperreflective dots. Optic disc is elevated. There is subretinal fluid, and there is Ballard or bacillary layer detachment, which is a split in the myoid layer of the photoreceptors. How do you differentiate between subretinal fluid and Ballard? You have to trace the bottom hyperreflective line. In a subretinal fluid pocket, there is a single hyperreflective line at the bottom, which is the RP, and in Ballard, you can see that there are 2 hyperreflective lines. All right, and then there is, of course, the thickened choroid, which causes RP undulations. Moving on to the FFA. FFA will show multiple pinpoint leaks. You can see them here, 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 all around, over here, here, here. And the fluorescein dye will fill the subretinal fluid pockets. Of course, there's a hot disk. This is another OCT scan from a different patient. The same features of subretinal fluid, Ballard, cells in the vitreous, thickened choroid, and RPE undulations. This patient also underwent an FFA, and you can see the multiple pinpoint leaks all around along over here with fluid filling, the fluorescein dye filling the subretinal fluid pockets. This patient also underwent an ICG where you can see early stromal vessel hypercyanescence and regular hypercyanescent dark dots in the late stage. Unless immunomodulatory therapy is started, recurrences are the rule in VKH. Recurrences are seen as anterior chamber reaction rather than recurrent posterior detachment. This is an EDI OCT of a patient with recurrence of VKH. There are no SRF pockets, but she had anterior inflammation, and the EDI OCT shows that the choroid was thickened, especially when compared to the previous visit. Now, in case of the convalescent phase or chronic recurrent phase, we say the retina becomes depigmented, which means it appears more red. That's why it's called sunset glow fundus. In the slit lamp retroillumination view, the glow is redder than the orange of a healthy retina. There can also be multiple subretinal bands, like you can see over here. Now, what are the goals of therapy? As with any uveitic condition, the first goal is to control inflammation as soon as possible, followed by preventing any structural complications, both of which can be achieved by systemic corticosteroids given quickly and at appropriate doses. The prevention of recurrent attacks and chronic changes needs additional immunomodulatory therapy from the first attack. Once the diagnosis is confirmed and after ruling out any systemic contraindications, high-dose systemic steroids in the form of intravenous methylprednisolone at 1 gram per day for 3 days, followed by oral steroids at 1 to 1.5 milligram per kg per day in undivided doses is important. Adding immunomodulatory therapy in patients with VKH at first attack is shown to have improved visual acuity and prevent the structural changes that can happen due to chronicity. This is a list of further reading. Thank you for your attention.